Welcome back, everyone, to part 5 of our 150-part inpatient diagnosis-related group masterclass. I'm your host, Harshal, and I'm absolutely thrilled to have you here today as we continue to decode the fascinating world of clinical coding. Before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Now, today's explainer is a massive one. We're going to cover the Uniform Hospital Discharge Dataset definitions, the UHDDS, and the absolute gold standard official guidelines for selecting your principal diagnosis. But first, let's quickly ground ourselves with a recap of our previous lesson. In Part 4, we spent some serious time unpacking present on admission or POA indicators and hospital-acquired conditions. Remember how critical it is to figure out whether a diagnosis was present at the exact moment the order for inpatient admission happened? That simple Y or N flag completely alters our DRG grouping. It dictates whether a condition can actually act as a comorbidity or major comorbidity, and it directly impacts quality metrics and reimbursement. Keep that fresh in your mind, because POA indicators intersect heavily with what we're discussing today. Okay, here's our roadmap for today. We've got our intro and recap, a breakdown of the UHDDS, defining the principal diagnosis, the core rules and guidelines, some real-world examples and pitfalls, and finally, a summary and a teaser for next time. So let's dive right into this. Section 1. What is the UHDDS? UHDDS stands for the Uniform Hospital Discharge Dataset. You can really think of this as the absolute law of the land for hospital inpatient data reporting across the entire United States. Its primary purpose? To standardize the definitions of the data elements that hospitals collect and report on every single discharged patient. So why does this matter to us as coders? Well, because UHDDS definitions literally govern all inpatient diagnosis and procedure coding. Whenever there's confusion or a gray area in a patient's chart, we have to defer back to the UHDDS definitions. It is our ultimate source of truth. Moving right along to Section 2, defining the principal diagnosis. I need you to commit this exact phrase to memory. The UHDDS defines the principal diagnosis as, quote, the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Notice the heavy emphasis I'm placing on the words established after study. This represents the clinical evaluation that happens during the entire length of the hospital stay. It's not necessarily what the patient complained of when they stumbled through the emergency room doors, but rather the final, confirmed clinical conclusion that justified keeping them in that hospital bed. Getting this right is absolutely crucial. Selecting the correct principal diagnosis is the highest stakes decision you're going to make on a medical record. Why? Because it's the heart of the inpatient account. It single-handedly determines the major diagnostic category, or MDC, that the patient falls into, which then sets the base MSDRG. In fact, getting this one diagnosis right accounts for roughly 80% of your final DRG assignment. If you get the PDEX wrong, the whole claim goes off the rails, resulting in skewed data and completely inaccurate reimbursement. Now, this is a distinction that coders, clinical documentation improvement specialists, and auditors have to keep crystal clear. The primary reason for admission is simply the chief complaint, the symptom that caused the patient to seek hospital care in the first place. It's the focus on day one, sure, and it's used for administrative tracking, but it does not determine the MSDRG. The principal diagnosis, on the other hand, is finalized only after clinical findings, diagnostic workups, and therapeutic responses are complete. It's the final answer. Think about it like this. A patient is admitted and their primary reason for being there is chest pain. But after the clinical team runs an ECG and checks cardiac enzymes, the workup establishes the true diagnosis, an acute myocardial infarction. Therefore, the principal diagnosis, the condition established after study, is the acute MI. If a coder just threw chest pain on the claim because it was the admitting complaint, the MSDRG would be totally wrong and drastically underpaid, simply because chest pain is just a symptom of the actual underlying problem. Let's look at the rulebook. Section 3, Core Rules and Guidelines. Rule number 1 covers 2 or more interrelated or comparable conditions. If a patient has a couple of conditions that equally meet the definition for principal diagnosis, meaning they were both present on admission, both caused the admission, and both were treated equally, you can actually sequence either one as the principal diagnosis. It just depends on the specific circumstances and the treatment provided. Rule number 2, though, is totally non-negotiable. If a symptom is followed by a confirmed diagnosis, that confirmed underlying diagnosis always replaces the symptom code. Like we just talked about, you never code the chest pain if you've confirmed the heart attack. Here's another scenario you'll see all the time. Acute versus chronic conditions. When a patient presents with a condition documented as both acute and chronic, and there are separate ICD-10 codes for each at the same exact indentation level, the rule is strict. You have to sequence the acute condition first. For example, if your patient is admitted with acute on chronic renal failure, you assign code N17.9 for the acute kidney injury first, followed by the specific N18 code for the stage of their chronic kidney disease. The acute flare-up is what drove the admission, so it claims that top spot. Now, listen closely to this next one, because it is unique to inpatient coding. If at the exact time of discharge, a diagnosis is documented as probable, suspected, likely, questionable, or rule out, the inpatient guideline tells us to code the condition as if it were established. This basically recognizes that in a hospital setting, the clinical workup was done, even if a 100% definitive diagnosis wasn't perfectly nailed down. But, and this is a huge but, do not confuse rule out with ruled out. Rule out means they still suspect it. Ruled out means testing proved it is definitively not there. Never ever code a ruled out condition. Section 4. Case examples and pitfalls. Let's see how this plays out in the real world. This is exactly where clinical documentation improvement, or CDI, becomes an absolute lifesaver. Look at that top scenario. Poor documentation in a discharge summary that just vaguely says chest pain completely ties a coder's hands. They have to code chest pain. The resulting DRG is super low, and the hospital is severely underpaid for the intensive cardiac care they actually gave. Now look at the bottom scenario. With solid documentation reading acute MI managed with PCI to LAD, the coder assigns acute anterior wall MI as the principal diagnosis. They link it to the surgical procedure, which leads to an accurate, much higher weighted DRG that properly reflects how sick the patient was and the resources the hospital actually used. Okay, let's combine what we're learning today with our last lesson on POA indicators. A patient is admitted strictly for pneumonia. 2 days into their stay, they take a turn and develop sepsis. Because the sepsis wasn't present when the admission order was written, its POA indicator is N. Because of that, sepsis cannot be the principal diagnosis. It didn't occasion the admission, so the principal diagnosis stays as pneumonia. The sepsis gets coded as a secondary diagnosis. It's a powerful major comorbidity, sure, but it doesn't take the top spot. To put this into perspective, let's talk dollars and cents for a second. The financial hit of missing these rules is huge. We have a real case study where a patient is admitted for pneumonia, has a bronchoscopy, and has secondary diagnoses of COPD and hypertension. Coded correctly, this maps to DRG 193, simple pneumonia with a comorbidity, bringing in about $8,500. But if the coder misses the COPD, or the doctor doesn't document it clearly, the case plummets to DRG 195, simple pneumonia without a comorbidity. The payment drops to $6,200. That's a literal $2,300 loss in revenue on one single chart, just because a secondary condition wasn't captured alongside the principal diagnosis. All right, Section 5, Summary and Part 6 Teaser. Let's wrap this up. So here are your non-negotiable takeaways. The UHDS writes the rules, and you've got to follow them without exception. The principal diagnosis is the condition established after study, not just the day one symptom. Confirmed underlying conditions always replace symptom codes. When you've got a condition documented as both acute and chronic, sequence the acute one first. And exclusively in the inpatient world, terms like probable or suspected at discharge mean you code it as established. Master these, and I promise your DRG accuracy is going to skyrocket. We've spent this entire explainer nailing down how to select the number one code on the claim, the principal diagnosis. But getting the core right is really just the beginning, isn't it? A patient's true clinical story is way more complex than just one diagnosis. What about all the other conditions they bring with them? And how do those shift the financial gravity of a claim? Well, in Part 6, we're diving deep into secondary diagnoses, specifically comorbidities, or CCs, and major comorbidities, or MCCs, and how they dynamically alter DRG weights. You definitely won't want to miss it. If you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Thanks so much for hanging out and learning with me today. Keep coding accurately and ask yourself, what else might be hiding in that patient chart? I'll see you in Part 6.